And thank you for having me. My name is Shauna Eberhardt. My position, I'm here at the state of North Dakota within the Behavioral Health Division. I am the clinical director within that policy portion of that division. And so what that means is I sort of oversee a lot of the different programs as a whole mental health for the state of North Dakota. And so I'm involved in several initiatives, including the Pediatric Mental Health Care Access Grant, as she mentioned. And so by training, I am a licensed mental health provider and also a licensed addiction counselor as well. A little bit about my background. I started off in the field in private practice and quickly moved to public service, which is where I've spent the majority of my career in the human service centers, providing direct care to individuals with complex co-occurring disorders. That's sort of always kind of been my passion. I just really enjoy some of those challenges and getting to meet some of those individuals and seeing the progress. And so, as such, in my previous position, at Southeast Human Service Center, I had the opportunity to work on developing a first episode psychosis program within that region. And I know you all, some of you might have been on the previous Echo with Monica McConkey. She is currently contracted through state of North Dakota to provide some of that education, recruitment, and outreach as it relates to those first episode psychosis programs. And so I did work closely with Monica as well as we were kind of figuring out what this means. We did a lot of training. We attended a lot of conferences. We did some really neat, had opportunities to do some really neat outreach and to try to figure out what these programs really were. So with Monica's presentation, I wanted to sort of make sure that that foundation was laid. And so I'm just going to review a few items from her presentation. But really today, I was hoping to give you all a better idea of what those programs look like directly in the state of North Dakota and talk about practical aspects of referrals, the treatment itself, how all of that works together. And then I had reached out to our first episode psychosis programs just to hear a little bit from them as far as what's been working well, what are some of the aspects that they are continuing to grow, and to give everybody an overview with that as well. So I'm going to pull up my presentation mode just to let everybody know if you have a question and I don't see it in the chat right away, please feel free to tag me and I will pause so that we can have opportunities for those questions as well. Okay. So to give, again, a little bit of an overview of the first episode psychosis program, these programs are they are a requirement of our mental health block grant. So the state of North Dakota applies for the mental health block grant year after year. Currently, there is a requirement of a 10% set aside that specifically goes to serving individuals directly who have experienced early episodes of psychosis. So we started this pilot program in 2 regions in North Dakota, at Southeast Human Service Center and at West Central Human Service Center, so Fargo and Bismarck. And we also have a goal of expanding that program further west to try to help reach some of those consumers and individuals who are in need in that area. One of the really neat things that we had an opportunity to do with our program, as recommended kind of by our partners and consultants, was that we had opportunity to name our own program. And so we came up with the name HELP, Healing, Empowering, and Learning About Psychosis, just as a really good acronym. Part of the reason for that is anyone who has worked with individuals who have experienced psychosis, there is a general fear. This is one of those diagnoses that really kind of comes with that heavy stigma. And so we wanted to be able to provide a name that was a little less daunting for people, empowerment, helping them understand that this is a treatable illness, particularly when we do catch it very early on. Okay. So a little bit about in early intervention. This might not be news to any of you, but it might be. So just wanting to kind of understand a little bit about the context of this program. Psychosis does affect many people around our nation. It does occur worldwide with an annual incidence of 15.2 per 100,000 individuals. And it usually does develop kind of in those early ages. So we see a lot of psychosis developing in those ages 16 to 25, typically men a little bit earlier than women. In those programs as well. A caveat to that is a lot of the new research into psychosis is also looking at women's health as a whole. And so they are looking at the prevalence of, psychosis postpartum, as it relates to some of those hormonal fluctuations, different things like that as well. So there is some really new and interesting research coming out about that that I'm hoping we'll be able to share more in the future. This particular illness or subset of symptoms is pretty significant in the healthcare system. It does currently account for 25% of all hospital bed days. Obviously these statistics are from a few years ago, so take that with a grain of salt, but accounts for all 40% of long-term care days. This is something that really anecdotally we feel here in North Dakota, some of those long-term hospital stays being related to that. And then 20% of all Social Security benefit days. That's a pretty significant impact on the financial system as well. The cost is estimated around $65 billion per year. As you look through those, I'm not a money person myself. I'm a clinician, but some people obviously we would find that to be a pretty impactful number as well. The research into this illness indicates that early intervention is absolutely key. We can reduce the duration and severity of later episodes and really increase functionality. So in speaking a little bit about who qualifies for our first episode psychosis help program, they do require a formal screening. What this might look like though is that you may find somebody in your practice, you're noticing some of the symptoms listed below that I'll go through, and you're saying, you know what, I think we might need to just look into this a little bit further. I'm going to reach out to the team itself. We do get a number of referrals that way. I'll kind of speak to that referral process a little bit further. But what they do is they're going to run through kind of a formalized screening process. We have a contract with an individual who provides training and technical assistance through the University of Connecticut called, her name is Dr. Tully. And she is an excellent resource for us as well, and kind of making sure we're using evidence-based screening tools within those teams and really trying to get to the bottom of what's going on and provide that best treatment. So some of the things that you may find if you have a patient that you're working with, kind of in that age 16 to 35 range. We also kind of give a little bit of a caveat to that, if it is a little bit younger, a little bit older, I would strongly suggest reaching out to the program anyway. Even if they are not the right program, they're going to be a great opportunity. They're going to take that opportunity to meet with that person and find out what program might best meet their needs, or there may be an exception made into the help program as well. So some of the symptoms of psychosis that are commonly seen would be delusional, false beliefs, hallucinations, so seeing or hearing things that others may not see or hear. You may notice incoherent speech, sort of that disorganization that can happen. We might notice some cognitive difficulties, so memory problems, trouble thinking clearly or concentrating. We often find that goes along with that set of symptoms as well. We may notice disturbed thoughts or perceptions. So if you're just working with someone and you're kind of concerned about, this belief system seems a little bit odd. Obviously we always take into account cultural contexts and our own kind of biases and beliefs with that as we're working with individuals, so that we're not automatically jumping to that conclusion. But it's always a good thing to screen for some of that as well. We may have understanding, the individual may have difficulty understanding what is real, so their perception of reality may be very different than what we are perceiving. We may notice poor executive functioning, so just ability to use information in front of us and make a decision with that. We may notice some impairment in that area as well. Or behavior that is inappropriate to the situation. You may notice affect differences, with really bad news. Some people, naturally get nervous and giggle, but we may notice kind of a consistency with some of those affect changes, or something's just not quite seeming right there. One thing that's important here, I think, to note as well, many programs sort of immediately say no substance use. What we have found is the co-occurrence of substance use with psychosis is so significant that we absolutely cannot rule that out immediately. And so if substance use is present, please refer anyway. I think those are things that we, can tease out if it is a substance-induced psychosis as that treatment progresses as well. I'm going to pause there briefly just to see if there are any questions on the qualifying criteria or kind of what to look for.
Looks like we had one question in the chat from Mabel.
Sure.
She's wondering, she's interested if occupational therapists are mental health providers in the FEP programs.
Oh, that's a good question. So each first episode psychosis program is a little bit different. That is something that we have looked into in the Southeast region. Occupational therapy can be used in conjunction and partnership with the help team. We do not currently have a contract or a formalized position on the team, but that is certainly could be a very necessary part of the process. And so part of what the team does, as I'll kind of speak to, is look at that, holistic care, and if there is somebody who might benefit from that, we are working on getting those referrals out there and ensuring that then that person becomes a part of the team, and that we can work with individuals who are needing that service as well. So really good question. Okay, a couple of the governing principles behind the help programming. A big focus of this is, I think a lot of times in the healthcare profession, we really look at symptom reduction, ultimately taking on the perspective that our central focus is limiting disability from psychosis. And so what that means is it might look very different for each person, but we're really trying to take that perspective of restoration of functioning. What we have found throughout this program is that as restoration of functioning happens, we do notice a decrease in symptoms, but that is not the primary focus. So we talk about recovery as a very personalized journey. We talk about, and assess for what skills that individual might need to be able to be successful in their life, and also taking into account family in that process as well. It does take on a shared decision-making framework, so understanding the preferences of patients and integrated those with provider recommendations. All of our providers have extensive training and motivational interviewing practices, and so that's one area that they do utilize pretty frequently to ensure that we're always aligning with what the client is really wanting, but also taking into account, risks and benefits in each step of the process as well. Cultural competence is also a huge necessary component of this interpretive framework of what's happening with the individual. So if somebody is experiencing, symptoms and signs of behavior, we really want to also understand like how that information kind of is being disseminated within that family system. What are some of those core cultural components and beliefs? And does it contribute to the perception of symptoms? Does it also include their recovery process, and making sure that we have a good understanding and a very humble approach to working with individuals, particularly with different cultural practices and belief systems as our own as well. So the first episode, Psychosis programs, they are team-based. They do require multidisciplines to be very effective. There are two different programs right now that are happening. Both look very different in their structure. So I'm going to go through a little bit of that with you as well. But generally, what a team would consist of is there is a team leader, an outreach and recruitment coordinator. Some teams across the nation embed those into their teams. We have one individual that we contract for through the whole state. That is Monica McConkey, who you have heard from before. We also include supportive employment or supported education, case management supports, psychiatry and nursing supports, a primary mental health clinician, and then peer support and family caregiver support as well. So again, I'll talk about each of those positions in a little bit of a context as well. So just talking about ground up, essentially, you are seeing someone in your practice, you're starting to notice some of these behaviors. What do you do? If you just have general inquiries about the program, or if you want to think about referring, you can contact Monica McConkey directly. I did include her number in there. You can also work directly with those human service centers and any human service center. Right now, those human service centers have open access hours, which essentially means it's walk-in opportunity. If there's concern that, potentially a person might not make it to that appointment or do that walk-in, contact the Human Service Center directly, and they can work with you as well on getting that person, a time, or even doing an outreach assessment to that person in the community. That is something that can take place as well. But within that open access system, we have done training with all of our providers. We do use a hub and spoke model within the human service centers. So what that means is that you can walk into any human service center and we will get you an assessment, that screening and triage the assessment as deemed appropriate, and then get you to the right place where you need to be. And so all of that, I won't go into a ton of detail because I could talk about this all day, but we're currently working on enhancing that process through the development of certified community behavioral health clinic certification. So you're really going to see that enhanced over the next few years as far as that initial kind of screening and referral role as well. The third way, though, that someone could get assessed is individuals could be directed directly to those help. They are there for that purpose to help screen and help to kind of discuss those programs, what opportunities. They also like to meet with the potential client and their family directly. That way they can kind of start that process by helping them understand a little bit about the program, um, what the pros and cons are of going through a program like HELP are, and then kind of walk through that decision-making process with the family as well. I believe everyone will get access to these slides once this is complete as well, so you should have all that information. So the program itself is time phased and time limited. This is based on an evidence-based model. And so what that means is that these particular interventions and this phased approach has been normed for this population. So that initial phase, that's really that engagement aspect. So that could be anywhere from months 1 through 3. As we know, things, especially with psychosis, do not move in a beautiful linear fashion. And so they may meet with the individual and that individual is like, nope, I don't want anything to do with you. And then maybe they engage the family for a while and provide some supports and say, what can we do to make sure that you can function in your daily lives and have the best support? And then maybe, that person has some conversations with their family and they're willing to reconsider. Or, we might be doing some motivational interviewing practices with that person, saying, well, I don't want to be on medication. Okay. Let's talk about other ways that we can improve your life. So what are your goals? We've worked with individuals in the educational system who really wanted to finish out a degree, and maybe that was the prime focus. And so, using that motivational interviewing approach to say, to walk through that process with that person and limit that disability of what they're experiencing. There's a lot of education provided in this beginning stage. Really, it's minimizing that stigma. We find that a lot of families that are coming in to this are really scared and don't know what the best steps are and don't necessarily know how to support their loved one. So the family component is very, very essential in this process. Also during this time is when we want to talk about safety planning, ensure that there is, adequate housing, resources and needs kind of in that Maslow's pyramid hierarchy sense, to make sure that the individual even has the ability to focus in on their healthcare practices as a part of their well-being. This second phase is ongoing intervention and monitoring. I'm going to speak to a little bit of the clinical interventions that we use in the next slide. And then that phase 3 is kind of what are going to be the continued needs of this individual and the family. This is really in those final months of the program. Maybe that individual really wants to do check-ins with a therapist in the community on a regular basis. Maybe they've got a peer support that will continue to follow up with them years in. At this point, we also want to have a strong safety plan that if they do have recurrence with their illness, how the family can also best help support them in those times of crisis and make sure that they are well supported for future as well. So in practice, again, I kind of referenced a little bit of that. Once those referrals are received, the team does contact the individual and their family directly. With that assessment process, the team members can then engage. They will do at some point a full diagnostic assessment with that individual. Then they will also engage remaining members of the team. Depending on the person, sometimes they found it helpful to engage with the person or the family first through the peer support. It can be helpful just to have somebody say, hey, I've been in the system. I understand the fear of what you're going through. Here's how I coped with that, or here's, how my journey went. That can really reduce that fear and stigma again, especially when they see someone who's, actively working in a professional setting. Again, kind of, trying to reduce that stigma of this as well. They do introduce that collaborative decision-making process, that safety assessment and planning. Once they're shifting into those intentional interventions, they may utilize specific clinical best practices, including CBT for psychosis. We did train a variety of our providers on CBT for psychosis at both clinics, and then also statewide within that hub and spoke assessment model, so that people are aware kind of those general principles as well. And then also provided training and support into supportive education or employment, which is also an evidence-based model. Peer support, we have a peer support certification process through the state of North Dakota. And so we do hire certified peer supports for this program. And then that family therapy and education. We use quite a few resources from our trainers across the state. So we did have an initial training contract with New York On Track, who provided kind of that base overview training of the model, the community-based service. So this is not a program that the individual has to come in for appointments. They may choose to, or it may be that maybe they're not in that place where they're able to do that because they don't have transportation, or maybe there's some fear and paranoia about their surroundings. And so these team members are spending a great deal of the time in the community with the individual and their family, kind of in their own context, to also alleviate some of that fear and engage them. So we have also had team members attend annual conferences each year since implementation. That's been a fantastic process. And then we do have some direct support that we provide to those teams. Dr. Tully, as I mentioned, she does ongoing training for CBT for psychosis on the more intensive front. She also does understanding psychosis trainings, and then family interventions. So she contracts with our teams. She is doing case reviews with them on a biweekly basis, running through some of those clinical interventions and providing that TA. So we do have that contract in place for both teams currently through 2025. Another aspect of these programs that we wanted to ensure that we put into place, as with any evidence-based programs, is ensuring that we had a fidelity model that we could work with. And so in August of 2023, State of North Dakota contracted with UND to provide an initial fidelity review to the evidence-based practice. And then they are also now contracted to provide ongoing reviews, monitoring, and general technical assistance to those teams as well. So I would tell you a little bit about our initial fidelity review so you can understand kind of where each team is in this development, as this is a very relatively new practice. It was not recognized by SAMHSA on their website as a well-supported practice until 2016. So the literature on this is still being developed. And so with our programs just starting in the last couple of years, we wanted to kind of get that baseline review and then go from there. So UND did some interviews with clinical team leads, our care coordinators, case managers, therapists, psychiatrists, and peer support specialists. At that time, we did not have supportive employment embedded into the team, but they do now at the Southeast program. They have an individual who is providing that service directly within the team. An assessor reviewed the health records checklist. They reviewed patient records prepared by a non-clinical staff member at the site, and then all program documents. Both programs initially in their baseline review achieved either good or high fidelity markers across about 79% of the components in the FEP FS1 scale. Both programs indicated that their clinicians had received that formal training and supervision in CBT, client psychoeducation, family education, and motivational interviewing, which were some of the basis of the program. And then both programs also provide pharmacotherapy, CBT, client and family psychoeducation, and peer support services, supporting health and dealing with substance use disorders when applicable as well. Okay, so a couple of differences within the teams. Our team at West Central is embedded into a larger team which serves individuals with complex co-occurring disorders. So they are located in that Bismarck region. They do serve that entire region of North Dakota, uh, so also rural outreach within that region as well. Their West Central team currently has one team. It consists of a team lead therapist, case manager, psychiatric nursing support, and then skills training and integration within their program. So they recently are looking at the addition of a peer support as well. And then they are actually going to be looking at following sort of the Southeast model of how they're doing practice. And so instead of being embedded into a larger team, they will be branching off and serving only first episode psychosis individuals within that program. So at that point, we are hoping that that will take place over the next year, looking at positions and how we can make that happen and support them with that technical assistance as well. And so in West Central, you can see they are currently serving 4 adult clients and 2 youth clients within the program. They have remained integrated, like I said, with that larger team. We will update kind of as that happens through the state of North Dakota as they are in that process of integrating, but you can still make referrals to that team. So we wanted to make that very clear that we're not pausing the program. We're going to continue to operate as is until we build that independent team as well. So the Southeast team is a little bit different. They are an independent team that do not serve other clients outside of the first episode psychosis program. And you can see a little bit of the difference in the number of individuals that they're serving. So they currently consist of a clinical team lead, an administrative team lead. Both of those individuals also still provide direct care to individuals. They also have a case manager. They are hiring for a new clinician. In addition, they have a peer support specialist and they just hired a supportive employment specialist. So they are working with a full team at this point. Their team currently serves 26 clients experiencing a first episode of psychosis. I did not have data as to, prior to this presentation, as to youth versus young adults, but I do know that they do have quite a range of individuals within that program. They are new programs, so keep in mind typical length of stay within this program is about 2 years. So they have had 2 successful completions in the program just this year. So these would be their first successful completions within that 2-year framework of getting started. So we were really excited to hear about those successes as well. And I'll talk a little bit about some of those. So a couple of the strength areas we wanted to highlight and how these programs are currently operating based on this fidelity review. So all services that are required within that first episode psychosis program are being provided within each human service center. They are offered to clients and they are tailored to those individual needs. As I mentioned, whether it's out in the community, whether it's a combination of different things, that's all being taken into account in those individualized treatment plans. A couple other of the notes from the fidelity review is that there was an indication that there was supervision. A significant portion of the program that was seen as a huge benefit within this fidelity review was the psychiatrist's willingness and ability to see clients on short notice, including multiple times when needed. So that's maybe a little bit unique to this particular program, just because, when we were working with this population that's historically, harder to treat when it comes to that stigma, particularly of medications, it can be quite a bit of work on the psychiatrist end in providing that motivational interviewing opportunities, collaborative decision making. So we were really, really excited about that finding within the fidelity review is that we have some really fabulous psychiatrists on board. The majority of the clients, so 92% of the clients currently met the diagnostic criteria. They did note that the programs take great care with working with clients who have previously experienced limited resources for diagnosing, managing, and treating their behavioral health conditions. So they are really targeting also those referrals coming in that are those of the highest risk. They do offer services to clients age 16 to 36, with all their current clients falling between the ages of 18 and 24. That was at the time of the review this past August. Clients were seen in person within 24 hours after the referral by a member of the FEP team. I think that's also really important to highlight because we know, in the past, behavioral health programs sometimes have had lengthy wait lists. This is a program that they are really on top of being able to get out there and see these individuals right away. They also take an individualized approach for each of those clients and then strongly recommend having that family component. So when I talked to the team, they really wanted to kind of emphasize that family piece. Without that, the program would not be quite as successful as it is. They also, worthy of note, I thought this point of the clinicians are spending an average of 75% of their time out in the community. So as I mentioned, this really isn't office based. They're going out there and they're meeting the individuals literally where they are, whether or not that is on a street corner, in a doctor's office, or in their living room. So just being able to provide some of that flexibility with the programs also. So some of the growth areas that we wanted to talk about as well, just to highlight, because again, these are relatively new programs within state of North Dakota. Um, the fidelity components and service delivery areas, we're looking to continue to prioritize improvement in these areas. So one of those was early intervention, and that is one of the reasons that I'm here speaking with you all today as well. So 75% of the clients at that time of the fidelity review had a history of psychiatric hospitalization before joining the FEP program. So 3 clients received that first episode intervention within that time frame, and half of the current clients were referred to program after their initial hospitalization. So this is filling a gap in service. At that point, the team was less than 6 months old. But what's really significant about this is that the earlier that we get this information and get the referral and get the program going, the better. So one of the things that we found out was we really had targeted hospitals as a method for this referral emergency rooms. And we were really hoping to target more, pediatric settings and primary care. So, seeing individuals maybe who haven't even gotten to the point of hospitalization. So people who are really just starting to experience some of these as well. These 2 other components, client retention and assuring fidelity, largely this was low on the fidelity markers because of the newness of the team. So really it was too new to discern retention. We're hoping to have more information about that the next go around. And then talking about working with funding to establish a fidelity scale in further depth. So we started off with our New York on track contract and looking at further options for that evidence base for ongoing as well. Okay, so I wanted to walk through just a couple examples of, people who may be in this program. These are made up examples. Obviously, with PHI, we didn't want to get too in depth, so just some examples that you may see. But these are some of the types of individuals and some of their characteristics that are involved in programs. So I just gave some examples here of client A, a 20-year-old male enrolled at a local university. Parents and roommates start to notice bizarre behavior, including conspiracy-like thinking, increased isolation, a lack of attendance in school, and maybe they've started a lengthy document to highlight government conspiracy unrelated to their studies. This type of example is not uncommon. What we see, in this particular age with university students, is that some of the first people who notice are those individuals who they're seeing every day, so their roommates. Often parents aren't seeing their loved ones as much when they're off in college doing their thing. So again, kind of also letting universities know kind of what to watch for if we're starting to see a drop in that academic success. And then noting, some of those other bizarre behaviors, things like that, that we can kind of catch right away and get these individuals the help they need. Client B is another example. Client B is a 16-year-old female whose parents have brought her in to see a primary care physician over some concerns. Often what we see with families is we're not their first stop. Typically, they're going to, the people that they've been working with and know and trust. So oftentimes this is the pediatrician or the family care physician that they are seeing, or even an emergency room if they're really seeing that crisis. They report she often appears as though she's listening to something others cannot hear. Her speech has started to become disorganized. She sometimes hallucinates. These again are just some of those warning signs to watch for, but something that a parent might actually come into one of you all before they might get to the behavioral health realm. Client C is a 26-year-old female who recently had her first child. Again, kind of speaking about the new research that's coming into this topic as it relates to women's health and psychosis. Very new research and very intriguing coming out of some of these studies. Her husband brought her into the ER after she started to exhibit bizarre behavior and refused to care for their infant, believing the infant is not her child but has been replaced. So wanting to give you some examples maybe of what this might look like and things you may not have, thought of before as being a resource. This program can work collaboratively with you as well to continue to kind of assess and monitor some of those issues as well. Okay, and before I go to the next slide of question discussion, I wanted to just share this document with you. I had asked the team members to kind of come up with some, give me an example of a case that they have worked with, and so I've redacted the PHI as well with this, but just to give you a little bit of an idea of kind of how this program then goes from taking that information and shifting into the actual service. So in this case, we did change a few of the demographics just to ensure that PHI was not exhibited here. So client is a 26-year-old single male who resides with family. Grew up in Africa and moved to the United States in 2005. Completed high school, attended some college, and has a history of working a full-time variety of jobs. Initially, the help team was called in. They were able to assist the client in securing some SSDI and working towards some payee services initially. He was noted to be quote unquote hard to treat during hospitalization by family. So again, we weren't getting him kind of quite in this beginning stage, but after hospitalization. He was placed on olanzapine 20 milligrams and Depakote at 500 milligrams. He was subsequently diagnosed with schizophrenia. It was being carried forward due to some ongoing negative and cognitive symptoms that they were noting. He did have a history of experiencing auditory and visual hallucinations. There was a history of paranoia as well. Currently, the client symptoms are being treated with medications, and those symptoms are managed well. So some of the things that they looked at was the functional aspect of these symptoms. And so outlining the chronic mental health symptoms for him, since this wasn't one that they were able to kind of catch early on, that had caused some severe impairment in functioning at that point, and was really a barrier to reaching his own life goal of having his own home. So some of those symptoms had caused some impairment across various settings, resulting in unemployment, poor memory recall and problem solving, social isolation, a lack of resources, poor motivation for a change, some cognitive dysfunction, significant familial distress, poor organization, time management, and really marked difficulty in caring for his health needs. So poor memory recall kind of related to remembering important dates, appointments, taking medications. What this team was able to do is they were able to kind of start with some of those collaborative decisions with him, get him in to see the psychiatrist and start working with their therapist. Family was really able to engage as well in learning how to provide support and carrying out that crisis plan. And what is currently happening is that this individual has been able to have some pretty significant success in being able to find employment and housing, continues to take medications as prescribed, and engages in that safety plan when necessary. So I thought those were pretty important to highlight as well. And then I just asked them kind of for what tips and tricks do you guys use when it comes to really being able to make this meaningful. How do you do it? How do you engage individuals? And so these were some of the things that the team had been willing to share with me. Is that they do utilize psychology consults whenever necessary. Again, working with Dr. Tully as well. Ensuring that they keep a fresh perspective on the case. They do utilize identifying appropriate stages of change when discussing the clients and the appropriate intervention. They like to start off with identifying activities of interest, and this is where the peer support is really utilized in starting to develop that relationship with that individual and kind of understanding and doing activities with that person to build that rapport. They then engage in behavior modification planning and often use activities, food or favorite beverage, to increase adherence to some of those treatment recommendations. So using contingency management as a evidence-based clinical support with this. They do hold meetings quarterly with the client, family, and service providers, and then update treatment plans during that meeting as well. So ensuring that they're utilizing kind of the team-based approach as a whole, even with community providers and family supports. Utilizing motivational interviewing with all clients. At times, they have had to utilize alternative treatment orders, which is, more that intentional intervention when someone displays very high risk factors and imminent threats to themselves or others. Historically, the team has said those have been successful and they have been able to kind of work through and use a more collaborative decision-making approach once that risk level had been reduced. They do try to schedule joint sessions in the very beginning with family, particularly for clients who have a very close relationship with their family, and then continue to make sure that they're following through with those supports, signing the release of information as the client deems appropriate. They often are utilizing basic needs as an engagement tool, so helping a client kind of get those basic needs, whether or not it's housing, food insecurity, some of those things that an individual might needs. They use a person-centered, non-threatening, or non-judgmental approach to really kind of work with that individual. So accepting that there are many versions of what we all experience and really wanting to engage with that client to the best of their ability. And so that was a lot of information I just threw at you, but I wanted to provide a little information or a little opportunity here at the end for some of those questions that you might have regarding the program specifically, or if you'd like me to return to a specific slide for more information. So thank you again. Are there questions or discussion points?
And feel free to just unmute yourself or utilize the chat to ask any questions.
I do see one in the chat. I don't recall if the HELP program was time limited. Yes, it is time limited to 2 years. And so typically they are working with that individual during that time. And that does not mean then that if that 2 years passes and we're not seeing progress, oftentimes what's happening is that they might be referring, particularly because they're occurring in the human service centers, they may be referring directly to another program within the human service center. So Southeast Human Service Center, for example, also implements an IDDT, integrated dual disorder treatment team. And so they may refer to that. Let's say if that early episode of psychosis, maybe they are better served. Maybe there's severe substance use that's happening and they're not in that early episode. It's more of a, down the road, they might refer into that program as well. So that's been a very nice aspect of having it at the Human Service Center, is that ability to kind of refer directly into some of those other evidence-based programs. But yes, time limited to 2 years, approximate.
Shauna, thank you for the information. When I was listening to it, and I see in our chat that we've had people from ambulance and paramedics and ERs in the chat as part of their roles. It reminds me of work that we did with the CIT in the city of Fargo, police training, and how they would respond to a person who is psychotic. And it's not necessarily a drug issue or a hostile issue, but how they are responding due to a hallucination that they may be having or in a psychotic episode. So just having these people, and thank you all for joining today on the ECHO and just for the information, Shauna. Thank you for sharing with us today.
Yeah, and thank you for everything that you do. I've been on the direct care side for most of my career, and I've probably worked with some of you in the past, in the moment situations. And it's always been a wonderful experience just be able to collaborate on some of these, and know that you are supported. And so, yes, if there are any questions specifically, you can reach out to the individuals that were listed on the slide or myself as well.
Any other questions? Okay, well, thank you so much, Dr. Eberhard, on the presentation, great information. And thanks again for everybody that participated.
Thank you all.
Great
Thanks for
day.
having me.
Yep.
You too.